Assalamualaikum class. How are you? Hope you are doing well at home. Diagnosis and management of upper GI bleed. Basically, in the gastrointestinal tract, if you remember the anatomy, it starts from the oral cavity, then the esophagus, leading to the stomach, duodenum, then the small intestine, duodenum, jejunum, small intestine, then the large intestine, the colon, rectum, and terminating into the anal canal. So if we divide the GI tract into the upper and the lower GI tract, there is the ligament of Treats at the second part of the duodenum. Here you can see with my arrow pointing towards the second part. So the ligament of Treats above this level is the upper GI. So any bleeding which starts from the upper GI, including the oral cavity, oropharynx, esophagus, stomach, and up to the second part of the duodenum. We can label this as upper GI. So today my focus will be on the upper GI. Rest of the topic, lower GI bleed and the mid GI bleed will be covered later. So acute upper GI bleed is a life-threatening abdominal emergency that is one of the most common cause of hospitalization. Patients come to the emergency department with GI bleed. As I've already mentioned, upper GI is defined as bleeding right from the source proximal to the ligament of Treats. So it is broadly categorized as variceal and non-variceal. What is variceal bleed? It is basically a complication of end-stage liver disease. The patients are cirrhotic, they have hepatitis, and it is one of the complications when the liver fails to work, patient present with the upper GI bleed. While non-variceal bleed is usually associated with peptic ulcer, and there are a lot of other causes of GI bleed which we will be discussing later. Upper GI bleed is 4 times common as compared to the lower GI bleed, and it is more common among the males as compared to the females. So coming to the causes of GI bleed, as I've mentioned, esophageal varices, there are other causes. Now, in this slide, we divide the causes according to the organ of the gut, like esophagus, gastric means stomach, duodenal, etc. So among the esophagus, esophageal varices is the most common cause. Then other causes can include esophagitis, means inflammation of the ulcer, esophageal cancers, esophageal ulcers, and Mallory-Weiss tear. Mallory-Weiss tear is a small tear in the distal esophagus that usually occurs with profuse vomiting or retching. Then among the gastric causes, the most common ones are the gastric ulcer, and other common causes are gastric cancer, gastritis, again the inflammation of the stomach. Gastric varices, just like the esophageal varices, there can be varices in the stomach as well, and Delphi lesions. Delphi lesions are the blood vessels protruding in the outside the lumen, and they can cause bleed. Coming to the duodenal causes, again the most common is the duodenal ulcer, and the other common causes are vascular malformations, including aortoenteric fistula. In this, aorta, which is the largest vessel of the body, forms a communication with the gut vessels, making fistula, aortoenteric fistula, and that causes a profuse upper GI bleed. Then again, hematobilia. It is called a bleeding from the biliary tract. The ampulla of Vater, which opens into the second part of the duodenum, if you see blood from that, then we label as hematobilia or hemobilia. Then hemosuccus pancreaticus is bleeding from the pancreatic duct. Again, this bleed from the ampulla of Vater, but it is coming from the pancreatic duct. Then superior mesenteric artery syndrome, it is a rare cause. This diagram highlights the causes again according to the frequency. In the esophagus, esophagitis accounts for 10%. The most common cause is the peptic ulcer, which can be H. pylori induced or NSAIDs induced. NSAIDs are non-steroidal anti-inflammatory drugs. These are the very common drugs which are used by the patients for the relief of pain. So NSAID-induced peptic ulcer accounts for 35 to 50% of the cases, making the most common cause of the GI bleed. Then coming to the varicose bleed, this is the second most common. It can be due to the liver disease, or if the liver is normal, can be due to the portal vein thrombosis. Then I mentioned earlier malrevised tear secondary to retching. It accounts for 5%. Esophagitis is 10%. Cancers of the stomach or esophagus are a rare cause in 2%, and the less common causes are vascular malformations, duodenal fistulas, and the gastric erosions. I mentioned earlier we divided the GI bleed into variceal and non-variceal. So what are varices? Varices are the dilated veins in the esophagus. Basically, these are the veins in the esophagus. Normally, they are not visible, but if they become dilated and tortuous due to the portal pressure, they becomes visible in the lumen of the esophagus, as you can see over here where I'm pointing out with the arrow. And if the portal pressure is so much high, then it ruptures and causes the bleeding. So in this figure, we have small varices, medium varices, and large varices, that is almost occluding the lumen of the esophagus. Then I am showing you few of the pictures of causes of the GI bleed when we do endoscopically. First, we diagnose the cause and then we treat. So endoscopically, here you can see this is the picture of the varices, and here this is the distal esophagus, and you can see a lot of ulcers and redness and bleed. So if the patient has esophagitis and bleeding from this side, we get the picture. Again, Barrett's esophagus is also one of the common cause. It is a complication of the GERD, and now here is a bleeding you can see from the esophagus. Then esophageal candidiasis is a fungal infection. It occurs in patients who are immunocompromised, like patients on chemotherapy, patients with the tumors, tuberculosis, etc. These patients can present with dysphagia, and if the ulcers are large, they can also cause upper GI bleed. And the other cause is the tumor. Tumor can be present anywhere, like in the esophagus, in the gastroesophageal junction, in the fundus, in the stomach, anywhere. Then, as I was discussing earlier, this is the ampulla of water in the second part. Here you see blood clot protruding from the ampulla. So if we find the source of blood from the ampulla of water, we label it as hemophilia. It can be from the bile duct or it can be from the pancreatic duct. If it is from the pancreatic duct, it is called hemosuccus pancreaticus. Now, after discussing few of the common and the less common causes of the GI bleed, let's move on to the signs and symptoms. So the most common sign is the hematemesis. Hematemesis is basically the is defined as vomiting of blood. It could be digested blood in the stomach. Digested blood means it is mixed with the food particles. That is coffee ground hematemesis. That indicates slower rate of bleeding. Or fresh or unaltered blood, that is gross blood, and clots indicates rapid bleeding. So if the patient emits vomitus of blood, either in the form of fresh blood or the digested blood along with the food particles, it is labeled as hematemesis. Another common presentation could be melena. What is melena? It is a stool consisting of partially digested blood, black or tarry colored. We commonly call it as black and tarry color, and it has a distinctive odor. So it indicates that the blood has been present in the GI for at least 14 hours. So basically this is the black stools coming from the anal canal, but the source is the upper GI above the ligament of Treats. So it takes 14 hours at least to pass through the entire GI tract, and it mixes with the enzymes which are normally present, enzymes and the bacteria which are normally present in the GI tract. So it gives the characteristic color and the odor to the stools. The more proximal the bleeding site, the more likely melena will occur. Then the third type is the hematochezia. So hematochezia, if there is fresh blood from the lower GI, it is called hematochezia. It is usually the lower GI, but if upper GI is so much massive, it is so risky that blood does not remain in the bowel. So it takes less than 14 hours. So it does not have time to become melanotic, and it passes in through the anal canal as fresh red blood. So these are the three types of bleeding which we commonly see with the gut. So coming back to our slide, these are the signs and symptoms, which includes hematemesis, melena, hematochezia, syncope. So obviously, when there is a blood loss, there is a hypovolemia, the blood pressure of the patient drops, and the patient feels dizziness and syncopes. Another common causes are dyspepsia and epigastric pain. In the patients who have history of ulcers, they take NSAIDs for a prolonged period. They can have the history of the dyspepsia, epigastric pain, heartburn, diffuse abdominal pain, dysphagia. As I mentioned, if the patient has like tumor of the stomach, cancer of the esophagus, or the infections like candidiasis, they can have dysphagia. Again, the weight loss can be due to the tumors or the prolonged chronic diseases, and the jaundice if the patient has liver disease, like in cases of varicose bleed, indicating that there is a problem with the liver. So how do we approach the patient? First of all, the history again. The history is very important. First of all, divide that the patient is what actually patient has. The patient has hematemesis, hematochezia melena. What are the associated features, and are there features of blood loss like shock, syncope? Is the patient anemic? Anemia usually indicates the chronic bleed or the profuse upper GI, as it takes time for the body to compensate and the patient becomes anemic. Then the features of underlying cause I have already discussed. The drug history is also very important. NSAIDs, as we have discussed, this is the most common cause of the GI bleed, but there are also other drugs which can cause the GI bleed, like aspirin, steroids, anticoagulants, and SSRIs. Then history of epistaxis, that is nasal bleed or hemoptysis. Hemoptysis is what? This is the bleeding from the respiratory tract. So the patient, if he is saying that he is bleeding from the mouth, first of all, make sure that is it hematemesis or hemoptysis. Means if the patient has history of any lung disease like cough, shortness of breath, and the blood is coming along with the cough, so rather than labeling it as a hematemesis, this patient might be having hemoptysis. So history of epistaxis or hemoptysis to rule out the GI source of bleed. Then past medical history is again very important. Previous episode, does the patient have similar episodes in the past? Patient is a diabetic or any history of a chronic disease like coronary artery disease, because aortoenteric fistulas are more common in these patients, the renal or liver diseases, and the pulmonary diseases. And past history of any abdominal surgery indicating any post-surgical causes of the GI bleed or some causes of the GI bleed related to the gut, like Crohn's disease, if the patient has underlying surgery and the patient has re-bleed, or the patient has surgery for the tumor and after that patient bleeds. So we have to look for the other causes. Rabia, it's totally silent. मेरे कुछ लग ही नहीं रहा कि कोई क्लास हो रही है या what? Hello? Is anyone online?
Hello, जी मैम.
Can you hear my voice?
Yes, yes.
Are you with me in the lecture?
जी बिल्कुल.
Oh, okay. So let me continue. So then how to approach with such a patient after taking the history and the past history, we go to the examination. The general physical examination, obviously the pulse, vital signs are very very important in cases of GI bleed, like the pulse. Patient is a thready pulse, means a very rapid pulse, but it is a low volume. It indicates that the patient has bled a lot. He has become hypovolemic, and now his heart is compensating. So the pulse is a very strong indicator of the degree of the GI bleed. Then again the blood pressure. Blood pressure, if the patient has, can be normal. If there is mild bleed, there can be orthostatic hypotension. Orthostatic means blood pressure uh, shift more than 10 millimeters systolic. If the patient is lying down, and if the patient is supine or standing up in position, so in the systolic blood pressure, this is called orthostatic hypotension. Then you have to look for the signs of the shock, like cold extremities, um, tachycardia, hypotension, chest pain. If the patient is having any cardiac problems, confusion and delirium, again due to the hypotension, hypovolemia, oliguria, definitely because of the low volume, the kidneys will compensate. The patient will go into the pre-renal azotemia and the pre-renal renal failure. Now the skin changes are also very important. Like in cirrhosis, we can have other indicators that the patient have cirrhosis, like palmar erythema, spider nevi. I will show you the pictures of these, then you will better understand. Then bleeding disorders. If the patient has generalized disorder, that can lead to the bleeding, but not only from the gut, from anywhere. So the patient can have the purpura and ecchymosis of the skin. If the patient has coagulation disorders, the patient can have hemarthrosis, like blood accumulation in the large cavities of the joints and over the muscles, so muscle hematomas and hemarthrosis. Then the signs of dehydration, apart from the vitals, you can also see dry mouth, mucosa, sunken eyes, skin turgor is reduced. Then the signs of the tumor is, if we are suspecting any GI tumor along the weight loss and GI bleed, other features can be present in the patient, like nodular liver, any abdominal mass, lymph nodes, etc. DRE. DRE is a digital rectal examination. DRE is a very important part of the examination in entire GI, especially in case of GI bleed. The patient can have fresh blood, local blood, bloody diarrhea. Patient can have melena, hematochezia. So DRE also gives a clue whether the patient, what kind of bleed the patient is having, and how much massive is he having the bleed. Then respiratory, for other comorbid diseases, respiratory, CVS and CNS. These are few of the pictures I will show, which I was discussing spider nevi. These are the small arterioles radiating from the center, and they blanch if occluded with the pinhead. If you apply a pressure with your thumb, this lesion will blanch, and then if you remove your thumb, this will reappear. So this indicates the patient can have the liver disease. Then similarly, the caput medusae, this is a sign of portal hypertension. The abdomen seems to be distended. There are vessels which are radiating away from the umbilicus, and this is umbilical hernia. So this is all the signs of portal hypertension. Then a palmar edema. There you can see the redness over the thenar and hypothenar eminences of the palms. Again, these are not specific, but these are usually present in patients with chronic liver disease. Then the white nails. Can you see this white nails? Can you appreciate this? So these can be present in case if the patient has low albumin. Low albumin can be present in the chronic diseases. It can be present in the cirrhosis. Then we were discussing the bruises and ecchymosis. So this is one of the lesion showing from the intramuscular injection, and this is from the venipuncture. They have clotting and bleeding deficiencies, so blood accumulate around the small vessels in the skin or in the muscles. So patient can get these kind of pictures. Now, after taking a very good history and the examination Let's come to the lab diagnosis. So first of all, we have to go for the complete blood count with platelet. CBC is necessary to assess the level of the blood loss. How much blood has been lost? CBC should be checked as 4 to 6 hourly, means 8 hour 4 times or 5 times a day. So if the hemoglobin was initially 12 grams per deciliter and now it is 8 after few hours, so we can say that the patient has dropped 4 grams. 4 grams is a lot of blood. If there is a more drop in blood, it means that the GI bleed is ongoing and we have to take measures immediately to stop the bleeding. If the hemoglobin is static, we can say that whatever the bleed is now stopped or it has slowed down. So hemoglobin. Hello. Hello. Who is there? Okay. The patient should be cross-matched for 2 to 6 units based on the rate of active bleeding. Hemoglobin level should be monitored serially in order to follow the trend. An unstable HB level may signify ongoing hemorrhage requiring further intervention. So immediately as the patient comes for the GI bleed, with the GI bleed, you take the cross sample and send to arrange the blood at least 2 to 6 units the patient might need during the procedure before or after to maintain the hemoglobin level. Then other tests which can be helpful, not directly with the GI bleed, but to confirm the underlying disease are the liver function test, renal function test to assess the damage to the kidneys or the previous renal disease, gastrin level to look for the secondary gastrinoma or primary gastrinoma secreting tumor of the stomach, and the calcium levels. The burn to creatinine ratio is also important in case of upper GI bleed. The urea is higher as compared to the creatinine. So burn to creatinine ratio becomes increased in case of upper GI bleed. Then prothrombin time is the PT and INR international normalized ratio APTT. These indicate the presence of coagulopathy, means whether it is deranged or not. Then prolongation of the PT, if more than 1.5 indicates liver impairment, and fibrinogen level also indicates the liver disease if it is less than 100. Now the most important procedure in the upper GI bleed is the endoscopy. Endoscopy has two reasons to do. First is to diagnose what is the cause of the GI bleed, and second is the therapeutic. Therapy means to treat the GI bleed. We have to treat with different methods depending on the source and the cause and the site of the GI bleed. We will discuss shortly all these things. So initial and diagnostic examination is the endoscopy, and it should be performed immediately if the patient has his saturation is not maintaining, or there is a chances of aspiration, so he must be intubated first and the endoscopy is performed. And there should be hemodynamic stability. If the blood pressure is very much low or the hemoglobin is very much low at the time of presentation, then we have to admit the patient in the ICU and then first make him stable by giving him fluids and blood products, and then perform endoscopy. This is the endoscope which passes from the oral cavity right into the esophagus and then into the stomach and the duodenum. And this is again another picture of the stomach. Other findings, investigations which help in the GI bleed is a chest X-ray to exclude aspiration, pneumonia, esophageal perforation. For example, if there is some procedure done and after the procedure like a dilatation of the esophagus or some stenting, and after that if the patient comes with a bleed and we are suspecting esophageal perforation, So before doing the endoscopy, first get these tests to confirm your diagnosis and then proceed accordingly, like the chest X-ray to exclude aspiration pneumonia, esophageal perforation, abdominal X-ray again to exclude the perforated viscera. Then CT scan can be helpful if we specifically suspect like aortoenteric fistulas and other causes, and the nuclear imaging are also helpful in determining the area of active hemorrhage. Angiography is the direct testing of the vessels. It is useful if the bleeding persists and endoscopy fails. For example, if we do the endoscopy, we do not find any site of the bleed, or if we are unable to control the bleed, so we can go directly for angiography, and it along with the transarterial embolization we can control the bleed. And in case of aortoenteric fistula, so in angiography there must be ongoing bleed at a rapid rate, then only we can detect the bleed. If the rate is low or if the bleeding is intermittent, the angiography report can become normal. So in summary, the diagnostic tests in the upper GI bleed can be, I should not mention colonoscopy, upper GI, small bowel endoscopy. These are overall diagnostic tests. Angiography, radionuclide imaging, barium studies, ultrasound or CT scan. Now, after we have diagnosed the history, examination, we have assessed the severity of the bleed. How do we manage the patient? This is the most important. Definitely, this is the reason of doing all this, that we have to manage the GI bleed. So priorities are to stabilize the patient, as I mentioned earlier, to protect the airway, then identify the source and treatment of the cause. Definitely protect the airways. We have discussed by endotracheal intubation or position of the patient on the sides. If the patient lie down supine, there is a chances that the patient might aspirate. So patient should be on the left lateral side, or patient should be propped up to protect the airways. And IV access, use 1 to 2 large. Why 2? Because if the one line stops, it's very difficult to pass another line first, because the veins become collapsed and it's very difficult to get second line in a very emergency and a rush. Then we have to take the blood samples for PEG cells and hemoglobin, send the cross match, then restore the circulation. We have already discussed the patient is hemodynamically unstable. First, we have to resuscitate the patient with the IV fluids, specifically colloids, at the rate of 500 ml per hour initially, and then according to his vitals. NG lavage. NG lavage is passing a nasogastric tube and aspirate the blood. It is sometimes indicated and sometimes not. So it is an important diagnostic tool, and it confirms a recent bleed that for example, if you are not sure it is coming from the stomach or from some oral cavity or from the lungs, so we can pass the NG and aspirate. And if it is coming from the stomach, you can say that it is GI bleed. Then active bleed, if it is coffee brown or red blood or a lack of the blood in the stomach, active bleeding less likely, but does not exclude an upper GI, because it might be intermittent, it might be slow, it might not come into the aspirate. This is the procedure of passing the NG through the nose. Nasogastric tube is passed again, just like the stomach, through the oropharynx, pharynx, esophagus, and then into the stomach. So what are the benefits of lavage? Better visualization during endoscopy. So if we aspirate all the blood, so the lumen of the stomach is clear, so better visualization. Then crude estimation of the rapidity. If you find the fresh red blood, it means a very active bleeding is going on. If you find the coffee ground, it means less active and rapid. Then prevent the development of PSC and cirrhosis, portosystemic, because GI bleed is one of the cause of the portosystemic encephalopathy. So if we aspirate the blood, it will not go into the circulation, so it can prevent the development. Then increase the pH. of the stomach and decrease the clot dissolution. Tube placement can reduce the patient's need to vomit during the procedure. So during gastric lavage, use saline and not use large volume. If we use large volume, patient can aspirate. And gastric lavage should be done in alert and cooperative patient to avoid aspiration. So these are few of the severity scores based on which we assess that which patient need immediate endoscopy, which patient needs ICU admission, which patient needs ward admission, which patient can be sent back home if no evidence of acute bleed, and endoscopy can be performed later. So for third years, you do not need to learn the entire score. Just remember the name of the score and the variables like age. As the age increases, the score increases. And then comorbid conditions, the presence of shock according to the pulse and BP, and the source of the GI bleed, and the stigmata means recent signs of the GI bleed. So if the risk is high risk of death and rebleed, and the risk is low, the prognosis is good. So we have already discussed to assess the severity, like if the bleeding patient has normal vital signs, bleeding severity is minus, you assume that blood loss is less than 10% of the body. If the vital signs patient has hypotension, bleeding severity is moderate, there will be 10 to 20% of the blood loss, and the patient is in shock, his resting blood pressure is low, there is massive GI bleed, the patient has lost around 20 to 25% of the GI bleed. So two large bore IV catheters we have discussed, oxygen by nasal cannula, monitor vital signs and blood transfusions according to the CBC report, and the fresh frozen plasma platelet transfusion according to the PT-INR and APTT report. So we have to transfuse platelet if the platelet count is less than 50,000. Fresh frozen plasma if INR is more than 1.5 times, and over transfusion should not be done. That is why we have to do the repeated CBC and PT-INR in 3 or 4 times a day, so that we do not over transfuse the patient, and have a check on the levels. Monitor the urine output, watch for the signs of overload. Then IV PPI, proton pump inhibitor. This is a very important drug which is used to control the ulcer bleed or erosions or non-erosive bleed. We have to give in the form of infusion, and the patient should be kept in NPO as soon as the patient arrives, as you have to perform the endoscopy near or later future. So you have to keep the patient straight away NPO. Now, in cases of varicose bleed, the patient should be given the vasoconstrictors, terlipressin, which should be started immediately if you suspect the varicose bleed, and should be stopped when the hemostasis is achieved or after 5 days of the GI bleed. Prophylactic antibiotics are very important because in patients with GI bleed can have other complications of the liver disease like secondary bacterial peritonitis, urinary tract infection, secondary infection, chest infection. So patients should be on prophylactic antibiotics. Then balloon tamponade should be considered as a salvage treatment. If the bleeding is not stopped by the endoscopic therapy, then balloon tamponade will be considered. This is the balloon which is used now. Its role is almost obsolete, but you can be asked that this is a balloon called Sangstick Blackmore tube, in which there are multiple pores. It is passed into the stomach and it is inflated, and gastric and esophageal balloon to stop the bleeding. So in esophageal varices, you have to do the endoscopy, identify the varices, and do the band ligation. This is the band ligator which we commonly use. These are the bands. These bands suck the varix, as you can see in this picture, and then the bleeding, the portal pressure is reduced, it mechanically basically occlude the vessel and then the bleeding is stopped. Then a stent insertion, if the bleeding is not stopped from the band ligation, then this is a procedure called TIPS. This is the shunt between the hepatic vein and the portal vein to bypass the liver to reduce the portal pressure. So this is used in case if the patient is bleeding is not controlled by band ligation. Then for gastric varices, we have to use this injection called cyanoacrylate injection, and again we can offer the tips if bleeding is not controlled with cyanoacrylate. Now coming to the non-varicose bleed, first of all again the endoscopy to diagnose the GI bleed, then we have to basically see what is the forest classification of the GI bleed. Based on this, we have these stages like jet bleeding ongoing, oozing of the blood, or only the visible vessel without active oozing, adherent clot, or any ulcer crater or clean based ulcer. Based on the findings on the endoscopy, we can assess the risk of rebleeding, maximum more than 90%, and the minimum is around 3 to 5%. And again, based on this classification, we can select the treatment, what is best for the patient. So many treatments available like mechanical method clips and injection with adrenaline or epinephrine, then thermal coagulation, fibrin or thrombin with adrenaline. Then sometimes the patient, if the bleeding is not controlled with all of these, then interventional radiology, which we have discussed. First we have to give them angiography, then angiographic therapeutic treatment to control the bleed. And so interventional radiology should be offered to unstable patients who rebleed after endoscopic treatment and refer urgently for surgery if radiology is not available, or again they are unable to identify the source or unable to stop the bleeding. So these are few of the pictures we were discussing, like the vessel is visible, bleeding, oozing of the blood, jet of bleed, or the black spot on over the blood indicating recent bleed, or clean based ulcers. You can see white ulcer with no evidence of active bleed. This is injection therapy. From the endoscope, we take out the needle and inject the drug into the base of the base of the ulcer to stop the bleeding. Now coming to the surgery, the indication for surgical treatment is persistent hypotension indicating ongoing GI bleed, failure of medical treatment or endoscopic hemostasis, coexisting medical conditions like if you are suspecting perforation after any procedure or obstruction or tumor. If the transfusion requirements are 4 units in 24 hours, means again it means the bleeding is ongoing. We are unable to control the blood bleeding, then refer to the surgery, or recurrent hospitalization means the patient is bled. We have controlled the bleed, discharge the patient. The patient is again coming in the same week after few days. Again, we are treating and discharging. Then again, the patient is coming. So, patient is recurrent hospitalization is also an indication to refer the patient for surgery. Then the types of operation depends on the type of the lesion. The herdias do not need to learn all the types, but these usually with the current endoscopic, modern diagnostic and endoscopic treatments, these days operations are less commonly performed. So there can be complications which can arise either from the GI bleed or from the treatment. Endoscopy related can be aspiration pneumonia, perforation, or the complications for coagulation or laser, and surgical complications like ileus, sepsis, and wound problems. Okay, after we have done everything, are there any possibilities that we can prevent the GI bleed, either the first episode of the GI bleed or the rebleed? So most important factor is to consider H. pylori. For H. pylori, we can give the antibiotics. So empirically, we can, with every GI bleed that is non-varicose, we can prescribe antibiotics to the patient, so the patient's H. pylori gets eradicated and the patient will not bleed. Or Okay, so another common cause is the NSAIDs. So we can ask the patient to stop the NSAIDs or use those NSAIDs which are stomach friendly, which do not cause damage, or entire coated aspirin which have less effect on the gut. So these are the most common causes which we can prevent for the bleed. Thank you for very much for listening to my lecture. And if you have any queries, any questions, you are free to ask. Anyone with me? Hello? कोई भी नहीं है अभी तो आवाज नहीं. Hello? Who is there? Anyone with me? Participants 251. Two participants raise hands. तो पुराना आ रहा है. क्या करूं? Hello? 3 participants raised hands. 6 participants. Can you hear me? What are your questions? लाल हो जाता किसी को. Hello?
जी मैम.
Okay. Yes, now I can hear. So any questions? Any student want to ask?
नो मैम, नो क्वेश्चंस फॉर द चैट रूम.
Okay.
और
So,
कुछ स्टूडेंट ने कहते हैं हैंड रेज किए हुए हैं,
okay.
तो आप उनको आपके पास चैट रूम शो हो रहा है, पार्टिसिपेशन शो हो रहा है.
Chat room participants तो हो रहे हैं show.
तो 3
Yes,
स्टूडेंट ने भी हैंड.
chat भी show हो रही है. Okay.
चैट में कुछ मैसेज आया आपके पास मैम?
No. Type message लिखा हुआ है. Type message here, but
नहीं 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 नहीं.
no. I cannot see any message. Recording आ रही है कुछ कोई record कर रहा है? Anyone?
जी आप देख लें अगर रिकॉर्डिंग कुछ कोई आपको वॉइस मैसेज कर रहा है या.
I don't know. यहाँ 5 participant raised hand तो आ रहा है.
जी जी, इनमें क्लिक करके आप उनसे क्वेश्चन ले लें. आप उनसे.
Okay, एक second. Start video. हेलो. नहीं वो कह रहे हैं क्वेश्चंस ले लें. हेलो.
जी मैम.
कैसे लूं क्वेश्चंस? आई डोंट नो.
मैंने मैसेज सेंड कर दिया है. 20 स्टूडेंट अगर आपसे क्वेश्चन की आप रिप्लाई करते हैं तो फिर आप उनका जवाब दे दीजिएगा.
ओके.
Ma'am, I wanted to ask
Yes.
a question.
Okay.
The question is that what are the findings on angiography? Could you please repeat that?
Okay, on angiography, we basically see the vessels, the part the part of the body which we are doing the angiography, like in the abdomen. If we are doing the angiography, we see the aorta and the vessels, and then we divide that according to the celiac and superior and inferior mesenteric vessels. And then again, the celiac has the branches of hepatic artery and gastric artery and all this.
Yeah.
So we see the vascular blush which is going into the aorta and into the distal vessels. If there is a bleed, we see that blood is going into the mucosa. So definitely the vessels to the GI and into the lumen. So if we see that vessel and that is giving any blush in the lumen of the gut, it means that there is ongoing bleeding from that area. Okay, can you get it?
All right. Yes. The other thing I wanted to tell you is that the chat is disabled basically. That is why the students are unable to question. Chat box is disabled for us.
Chat box is disabled for you. I don't know.
Yeah.
Okay. Let me open the chat box. Okay, I will do it. So any other student has any questions? Sonia. Does any student has any question?
चलो ठीक है, मैं भी इसका वही कर दिए तो जो है ना
हेलो नुमान, आपकी आवाज मुझे नहीं आ रही है।
जी मैम, आवाज आ रही है मैम आपको?
हाँ आप आ रही है जी। ठीक है, क्लोज कर दूं?
मैम क्लास ओवर होगी, क्वेश्चन एनी क्वेश्चन तो नहीं, और स्टूडेंट के फिर वो बाद में कहते हैं कि हमसे
वही
सवाल
स्टूडेंट्स कह रहे हैं कि चैट क्लोज कर दिए आपने, मैंने तो कुछ नहीं किया। क्या
अरे
बोलूं?
नहीं मैम, चैट तो ऑन है, असल में वो लोग खुद रिप्लाई नहीं कर रहे।
हाँ वो कह रहे हैं कि हम जो है ना वो बीच में जो है डिसेबल हो गई है आपकी प्रेजेंटेशन, हमने पूरी सुनी नहीं, और प्लस ये कि चैट डिसेबल हो गई है।
नहीं मैम, एज अ ये रेगुलर इश्यूज होते हैं स्टूडेंट की, कोई इशू नहीं है मैम।
जी चलें,
कोई
ठीक
मसला
है
नहीं, ठीक है मैम, थैंक यू सो
ठीक है,
मच,
ओके, थैंक यू।
अल्लाह हाफिज़।